GI and liver disease, they're all high risk. And again, during pregnancy, the risk increases, and the pregnancy has got an adverse effect on the GI disorder, as well as GI disorder will have the adverse effect on the pregnancy because of the conditions, because we are having patients with cirrhosis liver becoming pregnant, renal transplant patient becoming pregnant, and we have to identify the modifiable risk factors and make them condition good for conceiving. So either you can use contraception, or we can delay the pregnancy so that they conceive at an optimal time, so that they don't have any morbidity and mortality.
Multidisciplinary team, not only single obstetrician.
So
you also please include your medical G, others also, physician also.
So whoever is seeing all the medical disorder, they should be aware, and they should describe during adolescence. They have to have the discussion with the patient as well as parents and the in-laws. So because many a times we come across patients, the disease is not disclosed to the in-laws. So heart disease, GI, all those problems, they'll be taking tablets, but once after marriage, they stop all the tablets and become pregnant and land up in all complications. So that should be discussed, and they should be advised whether the pregnancy can be undertaken and what are the treatment options available, whether medical or surgical. If not ideal, they can go for other reproductive, assisted reproduction. Even nowadays, even to surrogacy, we should discuss with the patient and parents and in-laws.
Well said, madam. This my moderate perception is a good advice, good practice advice or best practice advice to optimize GI and liver disorder before pregnancy. Pre-conception contraceptive counseling by a multidisciplinary team. They also use a call MMF. I do not use the MMF here. We will have a combined team, will be good. They should engage for reproductive age persons who decide to become pregnant. We encourage. But at the same time, we should also sometimes discourage when they are having problems. So this is the point. Thanks. We'll go to the next question. But basically, for the PGs, this is most important. Whatever the state of the pregnancy, first trimester, second trimester, third trimester, the commonest cause in first trimester is viral hepatitis, second is gallstone disease, third is hyperemesis gravidarum, which is causing liver disease. Second trimester, viral hepatitis once again, gallstone disease, and ICP, which can go to the third trimester also. In third trimester, commonest is hepatitis E, the dreaded virus, and preeclampsia and HELP is, some people say, is a variant, and acute AFLP is nowadays increasing being seen because of better diagnostic facilities, and herpes hepatitis, which was forgotten. I want to bring it back. 335. If I am doing a DMK regime, I will put 335. If it's ADMK, I will put 445. Acha. Okay. The second question goes, Mrs. Yes, married for more than 1 year, 8th week of pregnancy, severe vomiting, throws up whatever she takes. How to proceed? The question goes to Poppy Rejoice, and if necessary, Madam also confident. Poppy, are you able to see?
The first question. The first question is what
is the reason for nausea and vomiting in pregnancy? Very briefly, one line for the mechanism. What is puke score? That is vomiting score is called puke score, nothing but. What is hyperemesis gravidarum? Is nothing but ultrasound diagnosis. What are the consequences? How do you manage? What are the contraindications of certain drugs? What are the precautions with respect to various antibiotics? This next 3 to 4 slides will do.
Nausea and vomiting is quite common in pregnancy.
Lower, back.
Nausea and vomiting is quite common in pregnancy. About 30 to 90% of pregnant women had nausea and vomiting. There are various reasons for nausea and vomiting. One of the major causes due to the hormone, progesterone. The progesterone causes dysmotility of the gut, and there will be diminished movements and will cause some bloating and lead to nausea. So there are other factors like hormonal factors, some allergy, some depression. These are various other factors that also contribute to nausea and vomiting of pregnancy.
This is score pattern, puke scoring. For PGs, when you are called for an opinion from the gynec ward, the early stages you have to puke score. Whether two things you have to know, whether the patient is having a alternative disturbance or not. If there is no alternative, there is a score is less than 12, more than 12, some people say. So, with the past, how many times you have nauseated, how many times you have thrown up, how many times you have retched. These scores are important. This is taken from American Journal of Obstetrics and Gynecology. Okay, what is the use of brat? I am a brat. What is the use of brat in pregnancy?
So that's what diet we advise them take bananas, rice, and this is as per ACOG guidelines. But for our patients, we say take frequent meals, and sometimes all the thali kiradala they'll have some vomiting. So tell them to avoid all those things. If they can find out the cause.
Avoid biryani.
Yes.
Most important. Yeah, right.
Even some smell can
Smell?
cause
Yeah.
vomiting.
Who smell? I don't know. Acha. Okay, this is a very dry topic. I have to make it some bit. It's a task mark state. I have to make some bit. Okay. What is the recommended dose for the some of the drugs? Ginger.
So ginger we can give 250 milligram 4 times, but normally what we give is pyridoxine with the doxylamine. It's a first line agents. And sometimes change of place, from husband's place patient go to mother place, they'll be completely all right. So we can advise that also. Because what we face in a regular practice, yeah, tell them to change the place, so they'll be all right at times. And if second line, we can go for H2 receptor blockers, as well as it is not completely under control, they are getting admitted, then in that case, you can go for ondansetron and metoclopramide.
I'm going to the safest PPA in textbook way back in 2003 textbook, they showed lansoprazole was slightly better than compared to other PPAs. Lansoprazole 15, LAN 30 they say. But we have seen so many drugs, nothing has caused any problems. It's only a conjecture. What is hyperemesis gravidarum, madam?
Hyperemesis gravidarum is a severe form of vomiting, and it is associated with 5% weight loss of pre-pregnant weight, and with dehydration and electrolyte imbalance. So it occurs in 5 to 10% of pregnancy. Severe vomiting.
No cause is not known. It is associated with so many points. Hyperthyroid, gonadotropin. So very high female to male ratio offspring, very low, high grade of low birth weight, which is a causing problem. What is the lab levels will be useful? Will it be useful? It's a dehydration, yes.
So electrolytes,
Yes.
we have to
Electrolytes and
see
liver.
electrolytes as well as a liver enzyme.
Okay. Ultrasound?
So ultrasound, we rule out any other apart from confirm intrauterine pregnancy, and see any other multiple pregnancy as well, and see for other causes for vomiting.
Molar pregnancy can also cause
Yes.
hyperemesis gravidarum. So we have to look for it also.
Why do you need a mental care approach for hyperemesis gravidarum?
So mental health, again depression, continuous vomiting, not able to take anything, and nobody to, sometimes if there is nobody to take care also.
Okay.
So we have to give the counseling, and some unwanted pregnancies or single parents, so all many nuclear families, nobody to help, many times they'll end up in hyperemesis, so we have to give them proper counseling.
Okay. Any problem with metoclopramide?
So actually it is not proven as such. Not proven. Maybe some studies say there may be a problem, very low risk of anomalies, but the patient is vomiting so much, landing up in hospitalization, there is no harm giving metoclopramide.
What is the thing you normally use? You use doxylamine or perodon?
Doxylamine and pyridoxine is the first line. If not getting control, we can give metoclopramide. Only thing, we have to be cautious of extrapyramidal side effects as well.
About ondansetron, madam, I have some inhibitions. That's why this slide was brought in.
Yes.
Ondansetron should not in the first line drug.
It is
Although it is supposed to be safe, some people say some of the congenital heart diseases have been reported, not exactly reported, some have been reported. It can be used when other things fail. So our things, doxylamine and
Pyridoxine.
that is pyridoxine can be used. Only when these don't take, ondansetron can be used. That's the point I want to make in this slide. The same thing repeated. Can you use steroids?
So it's very, very rarely, it's not responding, patient is becoming sick and sick, all the electrolytes becoming abnormal. In spite of our treatment, all the second line, very rarely we can use. But then again, we have to think about the problems with hydrocortisone. And
So
one more thing is the fluid what we give. So we told glucose containing fluid, only normal saline, and always give thiamine first. But actually, by the time the gastroenterologists come and see the patient, it is only the obstetrician who are seeing the patient first.
Okay.
So they should be, if at all asked, they should be guided that only normal saline fluid should be given, never glucose containing fluid. Patient might go on for precipitated wernicke's encephalopathy. We have seen 2 cases in our hospital in the last within 2 years.
Okay.
So
what you said, I repeat it. Why don't we say doxylamine, ondansetron, metoclopramide, steroids only in severe cases or refractory cases. You have to think of hyperemesis gravidarum always in mind. It's a molar pregnancy. Tamil is called muthu pregnancy, they say. Okay, endoscopy, this is coming to my field. Endoscopy, ERCP, gallstone pregnancy. It's a nice, it is so far from the dry area to the beautiful area, putting the tube in somebody's mouth. Acha. Mrs. M has history of abdominal pain, left fiber component, as well as in the right upper at times. History of UJ blade 3 years back. Details not available as usual. If endoscopy is contemplated, what are problems and called? Questions to Mala.
As we know, the endoscopy is a safe procedure, but in pregnancy, it has got its own complications on fetal outcome. So until otherwise, there is a strong indication, postpone the endoscopy as an elective procedure after the pregnancy. But here, there is a possibility of a bleed. So it could be a variceal bleed or it could be a non-variceal bleed. For therapeutic purpose, we have to do an endoscopy. If it is a variceal bleed, you have to go for an endoscopic variceal band ligation, and following which you have to give a beta blocker, and beta blocker also, it's a non-selective. It may have some effect on the uterine myometrium, on the beta receptors. And regarding if it is going to be a non-variceal bleed, it can happen in pregnancy because of a Mallory-Weiss tear, or it could be due to a peptic ulcer. Even in that situation, regarding the thermal method of therapeutic endoscopy, always use a bipolar cautery and use that grounding pad which we keep, it should be away from the uterus. You have it at the level of the shoulder.
We are coming to that. We are coming to that. So you feel DA endoscopy is safe, but to be done with the thing. What's the ideal trimester where the endoscopy can be done is second trimester. Always second trimester is good. Okay. When it's contraindicated, I'll tell you, placenta abruption, hypertensive pregnancy is contraindicated. Sedation, there is no drug which has got any territorial effect. Midazolam, but the ACOG guideline says limit use of midazolam. Most are short acting. What is the position of the patient will keep it?
It should be in the left lateral or with the pelvic tilt.
Why?
To prevent the supine hypotension syndrome.
Yeah,
the gravid uterus on the iotocaval compression.
After 20 weeks, you can go for supine. Before that, you only go for a left lateral position or left lateral decubitus. Bipolar cautery, as he told, is very better than the problem reaching the fetus. Elective endoscopy should be deferred until the postpartum period, but it's not possible. Then we should have a upper GI endoscopy, suggest second trimester. ERCP, I will question to Dr. Arun, the only male person in the entire panelist. What are the imaging endo options in gallstones in pregnancy? Now, everywhere you can do anything in pregnancy. ERCP pregnancy, when, what safety mechanisms? What is the risk for PEP? There is post-ERCP pancreatitis.
For gallstone, the investigation of choice is ultrasound itself.
Yes.
If we suspect any bile duct obstruction, we can consider MRCP or endoscopic ultrasound based on patient preference. Yes. So EUS can be considered in second trimester, but otherwise MRCP may be the
this is for the gynecology, madam. We can do, when you're doing ultrasound, it should be done entire body, abdomen, not only the gynec part. So some people have gone pain in the third trimester. I waited after delivery, we have gone for a CBD stroke. So whenever doing ultrasound, don't restrict it to your area, do the entire abdominal ultrasound. Always I insist on entire area ultrasound, entire abdominal ultrasound.
ERCP should be limited only for emergency indications, mainly cholangitis or persistent bile duct obstruction, which increasing bilirubin, which may occur in setting of bile duct stone or in the context of biliary pancreatitis. When we do ERCP in this setting also, it is better to have an experienced team with all supporting staff and a short and clean procedure with patient in left lateral position, midazolam if sedation is required, and try to use bile aspiration technique rather than use fluoroscopy to confirm the cannulation, and try to do only a stenting rather than do sphincterotomy, stone extraction, etc.
I think this was the point we did in Anna Nagar Peripheral Hospital when Jeevan Kumar was a professor, assistant professor. We didn't have CM. Necessity is mother of invention. So we used a bile aspiration technique and avoided sphincterotomy. Only put that way used. So, but still it is not foolproof. That one. What is the risk for post ERCP pancreatitis?
Sir, post ERCP pancreatitis, pregnancy is an independent risk factor for that. Risk is almost double compared to a non-pregnant woman. And in this case, we cannot use NSAIDs for prevention of post-exposure pancreatitis. So we will have to do with hydration of 1 liter with 1 liter of RL before the procedure, and try to minimize the time for ERCP.
The shielding is no longer required. What are the ERCP, which position they keep? Patient in the supine or prone?
Actually, left lateral can be possible. If left lateral can be achieved, that is the best. If not, can be made supine just for the cannulation part.
So you have some 2 more slides, sir. What are the measures to reduce the fetal radiation during ERCP? There are 2 slides you can tell for the PG experiment.
So,
Multidisciplinary team, use a modern fluoroscopy.
50 milligray is the cutoff for fetal complications, so we should try to limit the radiation as much as possible. Instead of using the loop or cine mode, we should use only pulses of the radiation. Nowadays, the new radiation equipment comes with a lot of safety precautions, so shielding is not a must.
Very good point taken. So pregnancy ERCP can be done in expert settings. Yes, sir, coming to you, sir. With the professor in there, I can't talk much, but anyway, this is for the PG sec, not for your level, sir. So ERCP pregnancy can perform for cholangitis. Patient has to live, whether the fetus lives or not. I want the mother to survive. So we are doing ERCP. It ideally should be done in second trimester, only second trimester, but if it comes in the first trimester, do you think I can avoid? No. So multidisciplinary tube, sir, please, want to comment?
No, sir, nothing. Today, I think we can move the ultrasound machine, and just the bile aspirate alone is not adequate. You can always pass a guide wire inside and the sonologist watches. This we've been doing for 33 decades, and we can do safely a sphincterotomy and even do a stone balloon extraction, because even the balloon can be seen inside.
Yes, sir.
By ultrasound. So it's quite easy and safe. Only thing is we have to be very careful not to enter into pancreatic duct, create post-ERCP pancreatitis. That is the only, you have to be utmost care you have to exercise, and do not keep on, even if once the guide wire enters into pancreatic duct, in this situation probably I'll put in a short 5 French stent.
Yes. So that is the pancreas stent. When will you remove, sir? When will you remove the pancreas stent?
Usually 3 times passage of the guide wire, we do that. But in pregnancy, even if once it goes, I would put in a prophylactic 5 French stent.
How long you
short
keep it?
stent.
How long you keep it, sir?
It will automatically fall off. Mostly it will very short Amsterdam type, without putting a pigtail and all that. Just an Amsterdam short 5, it will usually fall off.
Yes. Thank you, sir. So ERCP is a problematic area. That will pregnancy double problems, double dhamaka. Okay, gallstone pregnancy. I kept you waiting for a long time. Sorry. Patient is Mrs. L on second pregnancy, 10th week, radiating back, not exactly radiating back. Why gallstone is important? What is the ideal time to do surgery? What is the problem with the interval cholecystectomy? What are steps for high risk category? Is it possible to lap chole in first and third trimester? Always everybody says second and second. Can you do it in first and third?
So it depends on the individual patient. See, gallstones are important during pregnancy because the prevalence of symptomatic gallstones is much higher among pregnant women when compared to non-pregnant. This is due to various reasons. The hormone progesterone, which causes gallbladder dysmotility, and the change in bile concentration. Various reasons these people become symptomatic during pregnancy or immediately in the postpartum period. So whenever we deal with gallstone in pregnancy, we have to see where the gallstone lies, whether it is asymptomatic gallstone, symptomatic in the form of biliary pain, or presenting with acute cholecystitis, or complicated with choledocholitis, cholangitis or pancreatitis. So among these 5 categories, where the patient lies is the first question. So first is asymptomatic gallstones. If you have asymptomatic gallstones, better not to touch the patient, allow the patient to continue her pregnancy safely, give an alert of possible biliary pain. Second scenario is biliary pain, like the patients are said, this patient has biliary pain. So if the patient has come with biliary pain, it is an uncomplicated situation. Patient is not in cholecystitis, not in systemic symptoms, it's only biliary pain. So in such case, if the patient is in first trimester, we will try to manage conservatively and then allow to push the time and get the lab chole done, preferably in the second trimester. Similarly, if the patient has come in third trimester with the biliary pain, wait for delivery to happen and then do the surgery postpartum. Suppose if the patient has come with acute cholecystitis, we have no other option other than intervention. We can't manage conservatively unless it is really mild, where we can manage with some antibiotics, IV fluids and try to push time. Otherwise, in a severe acute calculus cholecystitis, we have to intervene, and lab chole is safer even during first and third trimester, but not as safe as in second trimester. First trimester is associated with higher chance of abortion, and third trimester, a preterm delivery can happen. So if it is a situation of acute cholecystitis, we have to proceed with lab chole even if it is first or third. Suppose a very high risk patient, like additionally preeclampsia is there, very difficult patient, then we can have a percutaneous cholecystostomy as a temporizing measure, stabilize the patient and then take the patient for cholecystectomy.
Well said. So bridging therapy is a bridging therapy. So salvage or bridging therapy, but interval cholecystectomy has got problems. So better to, even if it's third trimester, in a good center, try to do lab chole. That's what.
For cholecystitis. If it is biliary pain, we can wait and do it in second trimester.
So increasing evidence being shown. Now we can do safely lab chole because lab chole is becoming normally standardized. The complications are getting lesser. We can try in the first trimester when the conditions warrant it, right? So I think the question is answered. Now going to liver disease in pregnancy. We are fastly moving. Mrs. K, private 30th week of pregnancy, itching, you know what's the diagnosis, what's the problem? How to deal with other liver disorders? Questions to Malarmani and Manonmani. How to diagnose ICP? What is ICP? Intrahepatic cholesterol pregnancy. What is the cutoff level for the test which is being used for diagnosis? Is it done everywhere? What is the cost of the test? What is the mother and child with ICP? When to consider delivery? What are the guidelines? What will be the likely precautions?
Intrahepatic cholestasis of pregnancy, usually you will encounter in the second trimester of pregnancy because of increased bile acid. Usually the bile acid level will be 10 to 14. The cutoff will be more than 40. It is associated with stillbirths, and there can be even fetal miscarriages. And more than 100 millimoles, I think you have to take the bi-weekly monitoring with the obstetrician has to be done. And it is relatively better condition and could be managed with UDCA. UDCA at the dose of 15 milligram per kilogram, or even you can step up to 30 milligram per kilogram.
But madam, how many cases of ICP routinely see in a year? And ICP is only, we can prevent the maternal mortality. Fetus wastage is still there.
But it's very rare, we hardly see ICP cases. So probably 1 in 6 months, like that.
Not
Yeah.
common. But
Not very common.
Whenever the itching and there is the LFT. The LFT derangement is one of the worst words I can see in any, whenever call over comes. LFT derangement, I am getting bad. Tamil Manipun Solar Vijaykanth Adhimari. LFT derangement is definitely deranged. You have to do alkaline phosphatase will rise in pregnancy. That is a point. Whether it's accompanied with GGTP is important. It do in a fasting state important. Always alkaline phosphatase to be developed in a fasting state. And UDCA, yes, useful. When under, this is a guidelines,
Yeah.
but if it is as per guidelines, Society of Maternal Medicine recommends delivery at 36 weeks or a diagnosis at 36 weeks. Less than under, we will wait. We will monitor the patient. We will admit the patient, continue the admission. Then, as per the needs, we can do it at 36. If it's above 30, before 34 weeks, what will you do?
Before 34, we wait for the fetal lung maturity. We give them steroids. After 48.
What steroid normally used, madam?
So here we use dexamethasone.
Or beclomethasone?
No, it is
Dexamethasone.
dexamethasone 6 milligram 12 hours apart for 4 doses.
Why that is being given, madam?
It's actually Indian, we don't get the beta-methasone succinate salt as in US. So that's why we use only dexamethasone. Dose is 6 mg, 12th hourly 4 doses. So wait for that. And for neural protection, for intact neural survival, we give even magnesium sulfate for 24 hours, 1 gram per hour. And then with that, we shift the patient if there is NICU, good NICU care, or we can deliver them, depending upon the favorability.
So it's
So it avoids
these are
stillbirth.
guidelines from abroad, but we take it whenever there's 50 years. We don't go for 100.
100.
Our patients, we take it earlier.
But we get more of...
What's the cost of the bile acid test?
I think
You can be frank. There's no need. It is costly. What's the costly? It can be 500 to 1,500, depending on the center. It can be routinely done. It should routinely done is a motto of the doc. ICP is individualized. Other diseases. Primary, 33rd week of pregnancy, abdominal pain, derangement, LFT. What's the problem? How to tackle? This is for Poppy.
So the history is very clear. The patient is having the upper abdomen pain. So this is quite common in acute fatty liver of pregnancy, that too in the late part of the pregnancy. So in acute fatty liver of pregnancy, it's quite rare only, but we should be very careful. So this leads to organ failure is common, is a feature, as well as hypoglycemia is also very common. So the treatment is termination of pregnancy. So it's treated as an
That's the treatment.
emergency.
That is the treatment.
Actually,
When you
as
remove the fetus, the mother becomes all right.
Actually,
Because
as
INR is very
obstetrician,
high. It's more than 2 minutes for one patient. Once you remove that, once you injected that pregnancy, the mother INR dropped down to 18 seconds. This is a practical case I've seen in MMC in Ghosh Hospital. MMC, they say, they should tell.
so actually, as obstetrician, we always think HELP syndrome as a first cause. Patient having epigastric pain and altered liver derangements, we think it's HELP syndrome, but whether it is AFLP or HELP syndrome, the delivery is going to be the treatment. Only thing we are have a dilemma whether it is a HELP syndrome or AFLP. So we don't have any...
classification can clarify whether it's HELP or ICP or it's AFLP. Even some people say HELP is not a single variant. It can be a variant of PET, preeclampsia. That's what people say. Only thing, hypoglycemia.
Hypoglycemia.
Hypoglycemia is this point. And this is a classification seen everywhere. This can be used, but it's not always perfect. But you have to have other parameters. We go by one criteria called Swansea criteria. All are named after Britain. Swansea, Bristol, everything in Britain. But there is a criteria called Goyle criteria. That means no other explanation, liver derangement, pregnancy. Think of this disorder. The culprit is a placenta. Remember, the culprit, this study was done by Kumarasamy et al.
There is a modified Swansea criteria by
Modified
Ashish
Swansea
Goyal.
criteria.
INR is the criteria, sir, there, not just altered LFT. In a pregnant woman who is near delivery, who has abnormal LFT with high INR of more than 1.5, if there is no obvious cause, it is AFLP. Take it as AFLP. Problem with HELP and AFLP is there is some possibility of waiting for delivery in HELP, whereas AFLP we should not wait. AFLP is like MI. We should deliver immediately.
Whereas HELP, we can classify as per the...
So no, sir.
But the severity and mild HELP.
No, HELP also we deliver.
No,
HELP
AFLP is
also
immediate
okay.
delivery.
Okay. I can't go to the minute right. But what is the river which it is the classification of HELP is this? Famous North American river. It's a Mississippi classification. Otherwise Tennessee and
Mississippi.
50,000, 1 lakh and 1 lakh and above. That's normally use it.
Actually, if any mother dies with all this liver derangements and HELP syndrome, even we cannot document whether it is AFLP or HELP. So it is always branded as a HELP syndrome and its mortality. So even we document hypoglycemia, as you have been saying in all maternal mortality meetings, it is only HELP syndrome, unless proved otherwise. But how to prove AFLP? That is the only question from our side,
Do you do
sir.
liver biopsy, madam?
Sir?
Do you do liver biopsy for the mother?
No, sir.
Do you have any person going for liver transplantation after AFLP?
As of now,
As
either
of now,
mortality, maybe here PSG, I think they have done on liver transplant.
Case.
Yeah.
So that's the point taken. Okay. Second case, this is for Malar Nanikara. Mrs. B on second pregnancy, 10th week of pregnancy, period edema, patient having BP. What's the problem? How to tackle? What are the preventive methods?
This is preeclampsia. Here you have to manage the hypertension. You have to control the hypertension and the role of low dose aspirin. This can prevent the risk of fetal growth retardation. And
what is the week you should show? What is the dosage they say? I don't think we have 81 milligrams, we have 75 milligrams. We'll
So
start from
again-
12th, 16th weeks, they say, till the pregnancy over. Do you agree with that, or do you keep it at 36 weeks?
No, sir, here again there is a change. This is a ACOG guideline 81 milligram. But what we do is, we give 75 milligram, or if the patient is obese, 150 milligram. Especially if there is a case of severe preeclampsia or any APLA syndrome patients, we give as soon as the pregnancy test is positive and cardiac activity is confirmed, we start even before 12 weeks. And we continue, go on, give till even 2 days before delivery. That is a change. Yeah, it's not like 36 weeks as given in ACOG, given up to 48 hours, no harm.
Oh. So aspirin, frequent measure, what are the normal hypertensive drugs you use?
So it's only labetalol or nifedipine. If patient is on any other antihypertensive drugs, especially patient coming in before pregnancy, we should change over. If at all she has conceived with all our ARBs and AEBs, we should immediately switch over to labetalol. It is a drug of choice. If not controlled with labetalol, we go with the nifedipine.
Okay.
And hydralazine, ACOG says that we don't have hydralazine in our country in all hospitals.
My experience is limited. I don't know.
No, no, we don't have, sir. Except in very few corporates, we don't have.
Okay. The sir, I think it goes to sir once again from the ladies. Chronic FB in pregnancy.